looking at multidisciplinary perspectives on advancing care in challenging patient populations. So I'm Barbara Burtness. I'm a medical oncologist at Yale, and I'm joined by my colleagues, Arti Bhatia, also from Yale, and Ronnie Mehra, who's the section chief for solid tumors at the University of Maryland. I'd like to thank PeerView and the Head and Neck Cancer Alliance for providing this session, and also Johnson & Johnson and Maris for providing the educational grants for this symposium. If you have not already done so, I'd ask you to please complete the pre-event survey, and you'll see additional polling during the presentation. We've already had some questions come in through the online platform that we can see on our iPads up here, but please keep submitting your questions, and we'll have discussions and Q&A sessions where we can respond. For those of you who are in the room, so-called in-room learners, use your personal device to scan the QR code on the following slides so that you can respond to polls and ask questions. And for those of you online, so-called virtual learners, please respond to the polls on your screen and enter questions into the chat window. So this is the QR code. As you heard before, there's a gift card that's going to go out for high participation. Give you a second to take the photograph if you want to. Okay, great. Oh, should I go back? Sorry. A few cameras got whipped out at the last second. Okay, great. The slides and the practice aids can be accessed in the activity menu now, and you'll be able to download them after the session, and that's that QR code, and then the email to contact us is live@peerview.com. Okay, so what are our goals for today? Firstly, we want to talk about how immunotherapy via PD-1 inhibition is a mainstay of treatment for recurrent metastatic head and neck cancer. Then we want to look at a growing body of evidence that supports further study of EGFR-directed bispecific antibodies, including in combination with standard immunotherapy. We want to talk a little bit about how the bispecifics differ from one another in their toxicity profiles and activity for HPV-associated cancer. We'll talk about multidisciplinary workflows, dosing protocols, safety management, and how all of that might have to adapt if we get new approvals for the bispecifics. So I'll start by sort of setting the stage, current realities and future opportunities with immunotherapy in head and neck cancer, and start by just saying, where do we stand with approvals? So the agents that are approved are pembrolizumab, nivolumab, toripalimab, penpulimab, and tislelizumab, although the last one is still pending in the US. And the approvals for pembro and nivolumab are in recurrent metastatic mucosal head and neck cancer, pembro for first line in CPS1 as monotherapy, in first line in combination with chemo, in post-platinum, in the perioperative setting. For those of you who were at the session this morning, practice-changing data there. And although it's not specifically called out here, also patients with high TMB. And there's a sub-Q formulation that's approved, and that's approved with either Q3 or Q6 week dosing. Nivolumab is approved in the post-platinum setting as monotherapy, irrespective of PD-L1 expression, and the other three have their approvals in recurrent metastatic nasopharynx cancer. And so a lot of data went into all of those approvals. We don't have time to go through all of them, but I'd like to just briefly review some of the top-line data from Keynote-048. This was a randomized phase 3 trial that looked at either pembrolizumab monotherapy or pembrolizumab plus chemo compared to what was then the standard of care, which was doublet chemotherapy with cetuximab. And this took a sort of hierarchical approach to establishing benefits, starting with those patients who had the richest levels of PD-L1 expression, CPS 20 and higher, then all PD-L1 positive patients, CPS 1 or higher, then all patients. And what we found was that if you looked at pembrolizumab monotherapy compared to chemotherapy plus cetuximab, it was superior in those patients who were CPS 20 or higher. It was superior in those patients who were CPS 1 and higher, and the hazard ratio there was 0.74. And it was non-inferior in the total population with a hazard ratio of 0.82. And if you looked at pembrolizumab plus chemotherapy, here it was superior to chemotherapy plus cetuximab in all three groups. And if you look at the total population, you can see that the hazard ratio was 0.72, and you see 5-year survival going from 5 to 16%. But if you look at the CPS 20 patients, you have 5-year survival well over 20%, and that's the first time anything like that had been seen in head and neck cancer. Immunotherapy is reflected in the NCCN guidelines. So the preferred first-line regimen is pembrolizumab with platinum and 5-FU, which has a category 1 indication, although in the wake of the B10 trial, widespread use of a cisplatin or carboplatin plus taxane regimen is also justified with pembrolizumab. And then pembrolizumab monotherapy for tumors that express PD-L1 with a CPS of 1 or greater. And in subsequent lines of therapy, irrespective of PD-L1 expression, if the patient has not previously had a PD-1 inhibitor, either nivolumab or pembrolizumab. And I guess it's worth highlighting that there have been trials with PD-L1 inhibitors in head and neck cancer, but these have not demonstrated the same benefits. And so PD-L1 inhibition for the time being does not have a role in head and neck cancer. We do rely on biomarkers. So as I alluded to, we use CPS by IHC for PD-L1 very routinely to guide first-line systemic therapy choices. And the preferred assay is the DACO 2C3 assay, but a laboratory-derived test that's demonstrated equivalence is also used in some institutions. Tumor mutation burden has also been shown to predict benefit from immunotherapy in head and neck cancer. This is often part of the report when you get next-gen sequencing, although it's not really needed here in head and neck cancer where we have the approvals, but there is a tumor type agnostic approval for pembrolizumab with TMB high and for dostarlimab with MS high. And we do encourage obtaining next-gen sequencing panels to support clinical trials referral for the rare patient who might have a highly actionable mutation and for the TMB, as I mentioned. The question has been kicking around for a long time whether we can move beyond standard biomarkers for immunotherapy. And this is a very large literature. There were a lot of allusions to important papers in talks this morning. We wanted to pull out one very intriguing paper from NRG, their HN003 trial, which looked at pathologically high-risk HPV-negative patients who got adjuvant chemoradiation concurrent with pembrolizumab. And here they were able to show that post-treatment circulating memory T-cell subsets correlated with improved disease-free survival. They also suggested that baseline PD-L1 stromal immune cells correlated with improved disease-free survival, and intratumoral PD-L1 positive myeloid cells and disruptive p53 mutations were associated with worse disease-free survival. So I'd like to throw out a polling question now. And this is, how would you characterize the impact of immunotherapy on outcomes in HPV-negative recurrent metastatic head and neck cancer? So do you think it's transformative? Do you think it's incremental, but there's some clinical benefit there? It's limited to select responders? Or or you don't see any substantial impact whatsoever. And I think we'll have a little musical interlude while you all vote, and then we'll see how people feel about this. Okay, a quarter of you think that it's transformative. About 40% see an incremental clinical benefit. 26% feel it's limited to select responders, and 9% think there's no substantial impact. So a real broad spread, but I think the majority of you see the need for improvements anyway on this baseline. Okay. So we also wanted to dive in a little bit to HPV status, which is not in the package insert or the approval for any of these agents. But there are some data that suggests that there's some differences between HPV positive and negative patients. And so I'll start with here, if you focus on the top row here, these are the data from the Pembro mono to control comparison in Keynote-048, starting with CPS 20 and then looking at CPS 1. And you can see that the hazard ratios are pretty similar in the CPS 1, 0.64 and 0.75. But this really intriguing difference in the CPS 20, where the benefit of pembrolizumab monotherapy with a hazard ratio of 0.72 seems, and confidence intervals that widely cross 1, really seems different from the negatives with a hazard ratio of 0.57. If you go to Pembro plus chemo, doing the same kind of CPS 20, CPS 1, here you can see for CPS 1, favored across the board. But if you go to CPS 20, this dramatic shift with a hazard ratio of 0.39. So I think partly indicative of the fact that this is a group of patients who are still quite responsive to chemo. And so if you're putting Pembro up against chemo, you get a little bit less benefit because there's so much to be derived from chemo. You put them together, it looks quite active. And one of the reasons I think this is intriguing is that CPS 20 HPV positive population is one where people often think, oh, well, maybe I can get away with Pembro alone. And then turning to the Checkmate 651 trial, which was a trial of the PD-1 inhibitor nivolumab together with a CTLA-4 directed antibody. Here you can see that in the P16 positive patients, the benefit of immunotherapy was quite modest with a hazard ratio of 0.92, widely overlapping 1, in contrast to the P16 negative patients where the hazard ratio was 0.76. And so one question, I'm sorry, and we're also going to look at this in locally advanced disease. So here's the Keynote 412 study, where again it looked like there was a little bit more benefit for the HPV negative patients, and in the Javelin trial, where this was with a PD-L1 inhibitor, and overall immunotherapy was not beneficial here, but it was more deleterious in the P16 positive. So one of the questions that comes up is, are there differences in anti-tumor immunity in the HPV-associated cancers? Because you would think that sustained viral antigen expression should enhance immune targeting of HPV-positive cancers, but it may be that the greater impact of PD-1 inhibition combined with chemo it isn't really related to the immunotherapy, it's more related to the chemotherapy. And so the question is, are there subsets of head and neck cancer, for example, the NF-kappa B low HPV positive cancers that we know to be associated with tobacco use, viral integration, methylation, worse outcomes? Are they more immune cold? We know that HPV E6 represses the IL-1 beta promoter. HPV E7 increases expression of IL-18 binding protein, impairing pyroptosis. Methylation silences interferon response genes and expression of retro elements. So reasons to think that in HPV positive head and neck cancer, the anti-tumor immune response is a little bit different. So that's just some food for thought. Now I'd like to pass it over to Arti Bhatia to talk about evidence for emergence of bispecifics and newer therapeutics. Thank you.
Good afternoon, everyone, and thank you for joining us today. So we know that, and we heard that anti-PD-1 agents by themselves have limitations in efficacy with head and neck cancers, and there is obviously an unmet need for newer agents, which can provide synergy to anti-PD-1 blockade. So I will be providing a high-level overview of some of these novel agents in development. Let's start with a question. So what is the primary biologic rationale for EGFR-directed bispecific antibodies in recurrent and metastatic head and neck cancers? Delivery of cytotoxic payloads directly to tumor DNA, simultaneous EGFR pathway inhibition with immune effector activation, or direct redirection of T cells to tumor cells independent of checkpoint pathways. Great. So right off the bat, I think most of you, got this right. So it's simultaneous EGFR pathway inhibition with immune effector activation, and we'll talk a little bit more about this in the coming slides. Can we move on, please? Okay. So there's three major EGFR-directed bispecific antibodies that are being investigated in head and neck cancers. We'll talk about them sequentially. So petosemtamab is a bispecific agent that targets EGFR and LGR5. That's a protein on cancer stem cells. And this agent works in about three distinct ways. So one is EGFR ligand blocking. The other is EGFR receptor internalization and degradation, especially in LGR5 positive cells. And it also has an FC-mediated activation of innate immune responses, which drives antibody-dependent cellular cytotoxicity and recruits immune cells into the tumor microenvironment. And based on very promising early clinical data, which we'll talk about next, the drug received an FDA breakthrough therapy designation last year. So these were results from a phase 2 trial that combined petosemtamab and pembrolizumab in treatment-naive patients with PD-L1 CPS greater than or equal to 1 recurrent and metastatic disease. These results were presented at ASCO last year. This cohort had 43 evaluable patients and had a very clinically meaningful response rate of 63%. Responses were seen regardless of P16 status and across PD-L1 subgroups. The median PFS for this cohort was 9.9 months, and the median overall survival was not reached yet, but at 1 year, about 80% of people were alive. And this is very, very promising data just compared to historical data with pembrolizumab monotherapy. And the combination seemed pretty well tolerated, so most of the adverse events were what you would typically expect with EGFR targeting agents. Patients experienced acneiform dermatitis, there was skin fissures, rash, paronychia, electrolyte abnormalities. Of note, about 38% of patients did experience an infusion-related reaction. 7% of these were grade 3, but these could be decreased with better pre-medications and with prolonging the infusion time. And based on these promising data, there are 2 large phase 3 randomized trials that are currently enrolling patients with this agent. So LIGER Head Neck 1 is a phase 3 trial that is enrolling patients with treatment-naive, PD-L1 positive, recurrent and metastatic head and neck cancers. HPV positive and negative patients are allowed to enroll on this study. The planned sample size is about 500 patients, and these patients will be randomized 1:1 to get pembro monotherapy or pembro in combination with petosemtamab. And LIGER Head Neck 2 is another phase 3 randomized trial. This is in patients with recurrent metastatic disease who've already progressed on both anti-PD-1 and platinum-based chemo. These patients will also be randomized 1:1 to investigator's choice systemic therapy, which could be cetuximab, methotrexate, or docetaxel, or to the investigational agent. The next EGFR bispecific we'll talk about is ficerafusp alpha. This co-targets EGFR and TGF-beta, and we know that inhibiting TGF-beta signaling helps modulate the fibrotic and immunosuppressive tumor microenvironment, so there's greater penetration by effector T cells. It also helps decrease epithelial to mesenchymal transition, which can promote metastases. And this agent also received an FDA breakthrough designation, I think late last year, based on promising early phase data. And this was that early phase results that were presented also at ASCO last year. So this was a cohort of 28 patients, treatment naive and PD-L1 CPS positive, all HPV negative. These patients received combination ficerafusp and pembrolizumab, and this cohort had a confirmed response rate of 54%. There were deep and durable responses, so more than 80% of patients achieved more than 80% tumor shrinkage. The median PFS, again, in the order of 9 months, median duration of response, and overall survival were both in the 21 to 22-month range. Again, very exciting, very promising data for a high-risk subset. And this combination also seemed fairly well tolerated. The common side effects were, again, what you would see with EGFR inhibition. So you see dermatitis, acneiform rash, you see pruritus, hypomagnesemia. They also reported some anemia in these patients, but overall seemed like a tolerable combination. And there are multiple dose levels that are being explored of ficerafusp. There are phase 2 data that are reported with the 1,500 milligram IV weekly dosing, as well as with the 750 milligram IV weekly dosing. This cohort, which will be presented later this afternoon at the meeting, actually explores 2,000 milligrams every other week, so biweekly, in combination with pembrolizumab. Dr. Zenberg will be presenting this afternoon, so stay tuned for that. And the drug is now being explored in a phase 3 trial. Fortify Head Neck 1 is evaluating the combination of ficerafusp and pembrolizumab in treatment-naive HPV negative and PD-L1 positive patients. There was an initial phase 2 dose optimization cohort where the 2 different dose levels that we talked about, 1,500 and 750, were explored in combination with pembrolizumab, and the third arm was placebo. And based on the optimal dose, so I think they've chosen, as of last month, the 1,500 milligram dose as the optimal dose to go ahead in phase 3. And the phase 3 portion will now enroll patients in a 2:1 randomization to ficerafusp and pembrolizumab versus pembro and placebo. The study has a dual primary endpoint of objective response rate and overall survival. And the third EGFR bispecific is amivantamab, which already has an approval in lung cancer. This co-targets EGFR and MET. And we know that MET amplification drives resistance to cetuximab, especially in HPV negative patients. So that's the population that this drug is being explored in. So amivantamab can block EGFR signaling, MET signaling, and also can drive antibody-dependent cellular cytotoxicity, so it can also help recruit immune cells into the tumor environment. And Origami 4 is their phase 1/2 trial. This enrolled patients in multiple different cohorts. And cohort 1 results were presented at ESMO last year. So this cohort enrolled patients who had HPV negative recurrent metastatic disease, and they were refractory to anti-PD-1 agents as well as to platinum-based chemo. These patients received amivantamab monotherapy. 38 patients were evaluable for response, and the objective response rate here was 45%. Clinical benefit rate was 76%. Most of these patients had rapidly induced tumor responses. Their median time to response was 6 weeks. Median PFS was 6.8 months. Median OS was not reached, and for a median follow-up time of 8.3 months. So again, very meaningful numbers. This was a pan-refractory, obviously, and a high-risk population of HPV negative patients. And these are some representative scans. You can see a patient with HPV negative oral cavity cancer who had lung metastases and very nice response at week 7 on the scans on the right side. And the safety profile is pretty consistent, again, with a drug that targets EGFR and MET. So you see the similar acneiform dermatitis, paronychia, diarrhea, side effects that emerge from EGFR targeting. And classic with MET inhibition is hypoalbuminemia and peripheral edema. They also reported anemia and fatigue. Of note, this was a sub-Q formulation of amivantamab, so it's different from the IV formulation that was initially approved in lung cancer. So the rate of administration reactions has been very low. It was only 7% in this cohort. Almost all were grade 1 and 2. And treatment discontinuation for adverse events was also low. And this was cohort 3 from Origami 4, which evaluated amivantamab and taxanes, so paclitaxel here in combination in HPV-negative patients who were anti-PD-1 refractory. This was a smaller cohort, so 11 patients, but the objective response rate was high, 64%. And there is another presentation later this afternoon by Dr. Mara, so please do attend that too. This will present results from cohort 2, which was amivantamab and pembrolizumab in combination in treatment-naive patients with recurrent metastatic HPV-negative and PD-L1 positive disease. As a next step, amivantamab is now going to be explored in the first line in a phase 3 trial. This is Origami 5. It will be enrolling patients with HPV negative. All PD-L1, so negative or positive, are able to enroll to this study. These patients will be randomized in a 1:1 fashion to get the standard regimen of KEYNOTE-048, that's platinum pembrolizumab and 5-FU, versus platinum amivantamab and pembrolizumab. And this combination of amivantamab and pembro is also being explored in a small signal-seeking cohort as part of Origami 4 in the neoadjuvant setting. So this is a trial in progress. Patients who are being planned for neoadjuvant immunotherapy and have PD-L1 positive disease planned for surgery will be receiving 2 cycles of amivantamab and pembrolizumab in the pre-op setting. The adjuvant treatment aligns with KEYNOTE-689, so they will get radiation, pembrolizumab with or without chemo, and then maintenance amivantamab and pembrolizumab for 12 cycles. This is a trials in progress poster that will also be presented this evening. So now that we've heard a little bit about EGFR bispecifics, let's try another question. How would you now characterize the evidence to date with EGFR bispecifics in recurrent and metastatic head and neck cancer? Option 1, I can't say, not familiar. Option 2, limited clinical activity has been demonstrated. Option 3, activity seen primarily post-PD-1 settings. Option 4, activity in combination with PD-1 therapy. And option 5, activity both as monotherapy and in combination with PD-1s. Yep, so we didn't talk much about the single agent activity of petosemtamab, but there was a phase 2 trial with that agent as well, and we talked about amivantamab. So yes, these agents have been shown to have activity both as monotherapy and in combination with anti-PD-1 agents. Okay, I'm going to talk in the next section a little bit about the dosing nuances with these agents, because there may be a future where we have all three agents in our hands, and what do we do about this? So there are some differences and nuances to the way these drugs are dosed. Amivantamab is dosed subcutaneously every 3 weeks. It does utilize a step-up loading dose strategy. So in cycle 1, day 1, most patients get a lower dose of the drug. Day 8 and day 15, they get a full dose. And then starting with cycle 2, day 1, the drug is administered at the full dose every 3 weeks. Petosemtamab is being looked at intravenously. The dose is 1,500 milligrams biweekly, and that's the dose that's being tested in both LIGER 1 and 2 phase 3 trials, so both in combination with pembrolizumab as well as monotherapy. And Pfizer, so we talked about 3 different dose levels that are being explored, but the one that was chosen as part of the phase 2 optimization schedule on their phase 3 trial is 1,500 milligrams IV weekly, and that's the dose that'll be advancing to phase 3 in combination with pembrolizumab. And lastly, in my last section, I'd just like to talk about a few promising agents that are emerging in patients with HPV-positive disease. So the first is PDS-0101. This is an investigational cancer vaccine. It contains neoantigens, HPV-16 neoantigens, that work in conjunction with pembrolizumab it leads to a type 1 interferon response, improved antigen processing, cross-presentation, and allowing for more generation of HPV-16 specific immune cells. In a phase 2 trial of pembrolizumab with this vaccine in patients who were checkpoint therapy naive and had HPV positive recurrent metastatic disease that was also PD-L1 positive. 53 patients were enrolled. These results were presented at ASCO last year, and this cohort had an objective response rate of about 36% with a median overall survival of 30 months. And based on this data, there is a phase 3 randomized trial that is starting to enroll patients now. That's Versatile-3. And this trial will enroll patients with treatment-naive disease that are PD-L1 positive, HPV-16 positive. They will be randomized 2:1 to get the combination of pembro and the vaccine versus pembro monotherapy. This is a second agent that's in development, and updated results for this agent will be presented this afternoon as well. So this is ozuriftamab. It's a ROR2 targeting antibody drug conjugate. ROR2 is a cell surface receptor protein tyrosine kinase. It's enriched in multiple tumor types, including head and neck cancers. This drug binds conditionally to its target under the low pH conditions of the tumor microenvironment. So it's designed to limit off-target effects and side effects. And there were early phase results that were presented at ASCO this year in a cohort of 11 patients with HPV positive disease. These were heavily pretreated patients, and an objective response rate of 45% was reported here, with a median overall survival of almost a year. So again, updated results this afternoon for this agent as well. And lastly, we have another antibody drug conjugate that's in development. This is CRB-701. It's a next generation Nectin-4 targeted agent. It has a more stable linker that allows for better binding in the systemic circulation, but better delivery once it binds to its target in the tissue. And again, designed to have limited off-target effects, so to improve on the side effects seen with the older Nectin-4 targeting antibody drug conjugates. It also has a longer half-life, so it can be dosed less frequently. And there were dose escalation and expansion cohort results that were presented at ESMO last year in the head and neck group. And the response rate of 33% and 47% was reported for the two dose levels, the 2.7 and the 3.6 milligram per kilogram. And you can see some representative scans from patients in the bottom, so pretty dramatic response and early response at 6 weeks, which seems to be maintained at 1 year for this patient with HPV positive disease. So a lot of excitement and new agents on the horizon. That's all I have, and I'll pass it on to Dr. Mera.
Thank you. So now, after we've heard these two great presentations on the state of the field currently, next we want to move on to a case discussion, and really want this to be more interactive so we can kind of go through some of the nuances of the case with the panel. So this is a case of Max, a 62-year-old man with platinum-exposed P16 negative squamous cell cancer of the oral cavity. The PD-L1 CPS score was 8. He initially presented 9 months previously with locally advanced disease, T3 and 2B disease, and was treated with surgery followed by adjuvant chemoradiation. Currently, he's now presenting with biopsy-confirmed recurrent metastatic disease with a local regional recurrence in the neck. There's no signs of distant metastatic disease. Even though he does have a local regional recurrence, he has minimal pain and no airway compromise, and is able to maintain his nutrition and still has a good functional status, performance status of 1. During counseling, Max is asking about next steps, and he's willing to consider multiple options. So this is a patient that we often see in our multidisciplinary tumor board or multidisciplinary clinics in the recurrent setting, and so I think is illustrative of some of the key discussion points that we should have with patients at this point. So first, I wanted to get some feedback from my colleagues. So Dr. Bhatia, what would you say the prognosis for this particular patient is with HPV negative disease?
So, he's clearly had a recurrence. It's local regional within a year of completing treatment. So he does seem to have somewhat of an aggressive course. Doesn't seem like he has very rapidly progressive disease or a lot of symptom burden. But at longer term, I think his prognosis is really going to depend on whether he is someone who is able to get a definitive salvage surgery, or if we're resorting more to palliative treatment options for treating his recurrence.
And does the duration of you alluded to the recurrence within a year, so how does the duration of remission after potentially curative treatment inform?
Yeah, so it informs the kind of treatment options you have for this patient now. So for people who've recurred within, say, 6 months of chemotherapy, it limits the utility of chemotherapy for that population. For patients who've gone longer, like he seems to have gone 9 months after completion of definitive treatment, you're going to be able to consider that as an option if you're thinking systemic therapy here.
Okay. And so you mentioned standard options. So Dr. Burtness, what would the approach be in your current multidisciplinary clinics for a patient like this, and has it evolved from a year ago to present time?
Well, we have way more exciting trials for the unresectable patients. For patients who are resectable, there are some data now about the use of adjuvant PD-1 inhibition after resection with high-risk features, and there's an ongoing cooperative group trial, EA3191, where a patient who has either an involved margin from their salvage operation or extranodal extension, who's PD-L1 positive, would be randomized between sort of our older, I'm not sure I would call it standard of care, but something a lot of people did, which was reirradiation, versus PD-1 inhibition with pembrolizumab. Looking at this scan, I do think that we would be inclined to take the patient to the operating room. Maybe what you're trying to get me to say is that there would be some benefit to using an immunotherapy-based approach before the patient goes to the operating room. And I agree that that's a really intriguing thought, not one that we have a lot of data for in the salvage setting, and not yet in routine practice at our institution.
And I think that's an important nuance. When we counsel the patients, we're also talking about goals. And I think right now, if the still is a curative option, we still do consider salvage surgery as a curative option, and we can't really say that for the systemic approaches, even though we are seeing some exciting responses. Would you consider this patient to be a good candidate for a clinical trial with a bispecific and PD-1 combination, and how does their symptom burden inform the discussion?
So if it proved not to be resectable,
Yeah.
right? Like, so, say they took him to the OR and it was up against the carotid now, or
Yeah.
something like that, then I think they would be a great candidate for a first-line trial. They're HPV negative, so all 3 studies are appropriate in that context. I think that we don't really have enough data yet, I think, to say one or the other approach is associated with a better impact on symptom burden. Very curious what you'll be saying a little later today about amivantamab. However, I think all of those response rates being north of 50% are comparable to what we're expecting with IO plus chemo in a patient like this. And so I do think it would be very reasonable to offer this patient enrollment on one of those trials. Were the patient highly symptomatic, I would lean towards the Origami 5 trial of amivantamab because of the fact that the control arm includes chemotherapy, right? So in a highly symptomatic patient, you'd be worried about a 35 or a 50% chance of maybe ending up on pembro alone.
So, I guess I will speak to the impact of collaboration with the multidisciplinary team. I think, historically, a lot of times patients who had a local regional recurrence would be just going for salvage surgery. And I do think that there's more opportunity to have a discussion with the multidisciplinary team and even seeing the patient in a multidisciplinary clinic setting. Again, because of more nuanced discussion about goals of care, especially if a surgery may be morbid or be high risk. Some patients may elect to not proceed with that route. In the setting where somebody is not resectable, sometimes we do entertain reirradiation, but at our center, our practice is often to start with systemic therapy in those cases and to reserve reirradiation for the patients who are having a good response for systemic therapy. So in the salvage setting, we're rarely just going to reirradiation without first a trial of systemic therapy with either chemo or immunotherapy. And this is a setting where sometimes I would entertain a trial as well, if they're not resectable surgically, and even though potentially reirradiation may be something to consider down the line, I think it still is a reasonable setting to look at some of the trials, and again, if somebody has a good response and their symptoms are palliated, we can perhaps also defer the toxicities of reirradiation for the moment. I don't know if any of you want to add anything to...
No, we agree. So
So how does the multidisciplinary team prepare to deliver effective and function-preserving, when possible, and toxicity-aware therapy in the recurrent metastatic setting. So, I think head and neck cancers and treatment of head and neck cancers is unique in that even in the recurrent setting, I think we really work very closely with our colleagues in both in surgery and medical oncology and radiation oncology, and often come up with collaborative treatment plans. Even if a patient is going to go forward with palliative systemic therapy, they still need attention to their airway, they still need attention to nutrition, and so we still rely on the expertise of the entire multidisciplinary team to be able to provide that support. And then again, sometimes a salvage option may be possible. And sometimes, somebody may have a good response to systemic therapy, and in that situation, then we still do, like we discuss, is there a salvage consolidative option that we should be considering? We also, in our teams, really heavily rely on our advanced practice clinicians. They're excellent at providing compassionate symptom management and care coordination and patient education. And I think are also increasingly becoming very savvy at understanding toxicity management for patients on some of these newer agents and the novel toxicities that we're seeing there. Nutrition is still, like I mentioned, really critical, and many of our patients have had teeth pulled, in order to get their radiation. They still need dental care. They're still seeing our speech and swallowing therapists and pathologists, and then physical therapy and rehab for lymphedema therapy, and then for even just the scar that can build over time after head and neck radiation. And then obviously a lot of social needs. Depression is certainly been documented to be significant in this patient population. And so our social workers often help speak to that, and then dietitians are critical. So we really, at all aspects of the patient journey, do rely on this team. And I think especially for patients who are going on clinical trials, they really need all of the support that all of these members of the team can provide in order to be fit for the newer agents. I also want to stress the importance of palliative care. And so beyond even just end-of-life care, the symptom control that a strong palliative care team can provide is really critical, especially with regards to wound management, pain control, and so this is a critical part of the team as well, especially in the recurrent setting. So again, with all of this in mind, I think it's also important to really reflect on the goals of the patient, understanding the functional outcomes of all of their approaches and what their treatment decision priorities are. So want to acknowledge again the Head and Neck Cancer Alliance and all the resources that they are providing to our patients. This QR code provides access to their monthly newsletter, and really I think this is really essential to provide a community for our patients for support. And with that, I think we're moving on now to questions. So I want to reconsider Max, the 62-year-old man with platinum-exposed P16 negative recurrent metastatic oral cavity squamous cell cancer. Again, the CPS score was 8, had a low symptom burden and PS of 1. If all options were available, which strategy would you now select?
There's no surgery.
Oh. Well, I think 33 is probably, I'm not sure how to proceed. I think that's probably a reasonable answer. Again, I think this is a situation where we really, as a multidisciplinary team, really struggle to try to find the right answer. We just appreciated that surgery wasn't included as an option, and so I think probably that is an omission that we should also be considering in this situation. But for the PD-1 monotherapy, again, with somebody with a low symptom burden is reasonable, although the CPS score was still somewhat modest at 8, so under 10. Again, if quality of life and trying to minimize toxicities was really essential, I think that's reasonable. But chemo plus PD-1 is also reasonable. There has been emerging phase 2 data with PD-1 and cetuximab, and which has shown activity, and there's an ongoing alliance trial looking at this in the first-line setting compared to pembrolizumab monotherapy for platinum refractory patients, and so I think that's something to consider. I think with the toxicities of reirradiation, many of us also probably wouldn't do that initially, and like I mentioned, we're kind of saving it more in the consolidative setting if somebody has a good response to clinical therapy. And I do think for somebody, as mentioned before, who's not a surgical candidate, this is an appropriate patient for clinical trials if they're not a surgical candidate. Okay. When treating a patient like Max, what is the optimal time to re-engage the full multidisciplinary team? Before making decisions about systemic therapy was the majority, and I think that certainly is appropriate. Only if considering reirradiation and surgery with a little bit less, and then only if progression occurs with systemic therapy. So or after initial systemic therapy response. So the other three were somewhat split. But many of these patients had already been treated with a surgery or radiation colleague in the locally advanced curative setting. So I think it's reasonable to re-engage the entire team early in the process because they likely are already known to the patient. And then for this patient, just to recap, multiple options are represented in the current standard of care requiring multidisciplinary team discussion. Again, if the patient is not resectable, chemo plus pembrolizumab, potentially PD-1 inhibitor and cetuximab, or reirradiation, and then again, salvage surgery if that's feasible. But bispecifics do also have the potential to aid or replace current options as data is emerging. And I think that's what we'll have to wait and see if it shifts the balance or is incorporated into the use of local regional therapy. So I think with that, we have time now for questions.
Yeah, wonderful. Thank you. So as you're thinking about your questions and using the QR code to submit them, we have a few that are already online. And I will kick the first one to Dr. Bhatia. Do you foresee a role for EGFR bispecific combinations in locally advanced head and neck cancer, either perioperatively or in the adjuvant setting?
Yes, so I think those are the trials of the future. As we get more data about the efficacy of EGFR bispecifics in the recurrent metastatic setting, I think a natural transition is going to be to want to explore them, especially with the emergence of Keynote 689 data in the peri-op setting, in the adjuvant setting, to see if we can even improve on the outcomes of cure with the initial diagnosis and hopefully avoid some of the recurrences and distant disease.
Great. Dr. Mehra, given that the EGFR bispecifics have different mechanisms, do you think the varying targets might inform patient selection in the future?
I think there is a potential for that, but I think in order to do that, we need robust biomarker development as the current trials are evolving to help appreciate how, presence or of the different targets may inform which patients should be selected. But I think that's the opportunity with so many choices is to try to, determine the best agent for each individual patient.
Now we have a question from a patient, from a participant who possibly lived through the debates this morning after the keynote session. Still not clear on which patients are candidates for perioperative immunotherapy versus adjuvant in locally advanced head and neck cancer. And then there's a second question, what's the impact of HPV status here? But maybe I'll ask each of you to say who you think of preoperative Pembro and a Keynote 689-like approach for, and who you think of Nivo post-op for? Or do you not believe that either is the standard of care?
So for starters, I think it's really important to have multidisciplinary consultation for patients when making this decision before they move on to any treatment. And we are trying to get PD-L1 CPS scores for everybody in advance to help make that decision, although I appreciate Dr. Haddad's point on that sometimes can delay care a little bit, but we try to minimize that. My personal feeling is that the Keynote 689 regimen is the one that's FDA approved and has the level 1 data and the NCCN, and I believe in the value of that vaccine approach of priming with a checkpoint inhibitor before the surgical resection, and I think we have robust data that shows the value of that approach. But there are some patients who are very symptomatic and the actual response rates are still modest, and so there are some patients who I worry won't tolerate 2 doses of immunotherapy and waiting 6 weeks for surgery, or they have a rapidly progressing cancer that there's just hesitation to wait that long, and so in those situations oftentimes we are just moving forward with surgery, and then I appreciate having the Nivo post-op data to then consider if they have high-risk features.
Dr. Bhatia?
Yeah, so I agree. I think at our site too, we're trying to employ the Keynote 689 regimen for almost all pre-op patients. I kind of tend to reserve the Nivo post-op regimen for patients who maybe were understaged or not adequately staged at the time of diagnosis and are now upstaged pathologically. And those are the patients that we have been utilizing the Nivo post-op paradigm for.
Yeah, I think one of the reasons, first of all, I really agree with the point that there's a biologic rationale for giving the PD-1 inhibitor while the lymph nodes are intact, because we believe that the stem cells that lead to the effector memory T cells that reside in the tumor-draining lymph nodes are much more specific for the tumor than those from more distal sites. But another thing that I think is really important about Keynote 689 is that it incorporates many more patients than the Nivo post-op. And if you looked at the forest plot that was presented at AACR last year, the stage 3 patients were deriving at least as much, if not, probably a little bit more benefit than the stage 4 patients from this upfront approach. And so if you confine yourself to the patients who have the high-risk features, there's a group of patients who you have every reason to believe is going to have at least an EFS benefit, if not an OS benefit, from upfront exposure who get left out. The other thing I think is that there are some patients who post-op are not going to be ready for either immunotherapy or chemo-RT in the time window that Nivo post-op allowed, and the fact that they didn't get it preoperatively then might mean that they never get it. So we do really prioritize the neoadjuvant approach in our center, but just a couple of weeks ago we had somebody who we thought was going in for a T2N0 cancer and had a bunch of nodal involvement, and I wasn't quite high enough risk for Nivo post-op, and that was one that sort of fell between the cracks. And so I think we're going to have to also get better at really getting that PET scan in time, or understanding when we need to do a little bit more to figure out if there's nodal involvement. Okay, we have a couple of more minutes. Here's one. Would Pembro and chemo still be recommended for patients with comorbidities such as diabetes or kidney disease?
Yes, I think it certainly depends on what their renal function is, but there is data with the B10 study of carboplatin paclitaxel with pembrolizumab, and I think many people feel like this is more feasible than platinum 5-fluorouracil pembro, and so I think for patients who have some baseline kidney dysfunction, it's reasonable to dose with carboplatin.
Great. Dr. Bhatia, do we have any early signals on durability with EGFR bispecific plus PD-1 combinations, and might HPV status influence response duration?
So we definitely have data on durability with some of these agents. So ficerafusp had median PFS data presented. It was 9.9 months. They also presented median duration of response, which was 21.3 months. Some of that data is still evolving and maturing with the other two agents, so with petosemtamab and with amivantamab. I'm sorry, I forgot the second part of the question.
HPV status.
Right, and so HPV has been like a stratification factor for the petosemtamab data. I think they did note some responses in HPV positive patients, although it was a smaller cohort. It was 8 patients, I think, on the peto and pembro combination trial. HPV is not being permitted to enroll to the ficerafusp phase 3 or to the amivantamab phase 3, so I suspect more limited responses there with those agents, but definitely we'll see what the peto trial shows in phase 3 for HPV positive.
Great. In patients who progress on PD-1 based therapy, is there a meaningful role for adding or sequencing an anti-CTLA-4 agent?
I don't think that we have data currently that shows that that would be sufficient to reverse the immune refractory state if somebody progresses on a PD-1 inhibitor, and there had been a couple trial efforts with ipi-nivo and then also with tremelimumab and durvalumab looking at these combinations in head and neck cancer, which didn't really move forward. So I think probably looking at some of the newer agents is the strategy I'd prefer instead.
That's certainly been our approach at Yale. I will say that if Maura Gillison or Robert Haddad were in the room, we would probably get a different answer. And I know there are anecdotal reports of patients who've responded to the doublet who haven't responded to single agent. I think if you delve a little bit deeper into Checkmate 651 or into the I can't always keep all the different raptors.
Kestrel. I think it's Kestrel.
Eagle, Kestrel, hawk. There were subsets of patients who clearly benefited from immunotherapy. In the 3-arm study with tremelimumab, it was hard to see that there was any additional benefit from the CTLA-4 drug, but it would be those patients with high TMB and CPS 20 or higher who you expected to be immunotherapy responsive and then they weren't, where if you were going to do this, you might think about it. But I have to say, with the ADCs now, many trials available to immunotherapy experienced patients, I would prefer to see a patient go on to an ADC over trying that approach, which doesn't really have any high-level evidence behind it. So we are coming to the end of the hour. I want to thank you all for joining us. After the session concludes, you can scan this QR code or go to the website, peerview.com, MHNCS26 ARS, and claim credit and